Dr. Sunil used to facilitate your session. Today, due to some issues, I'll be doing the facilitation. Myself, Dr. Sridevi, working with Palliative India for last about 8 years. And I am more than glad to welcome Dr. Lulu Mathews for conducting this session on GI symptoms. I've known her since I was a student in Calicut, known as a a good pediatrician at that time. And then I heard about her from my husband, obviously. And then she is retired as a head of department of pediatrics from Calicut Medical College. And after a few years, I met her in palliative care when I joined for the National Fellowship in Palliative Medicine course in Calicut. Then I had an opportunity to attend a few sessions from her, and I still remember those sessions really well. And Madam is right now the Director of Academics in Institute of Palliative Medicine, Calicut. As you know, that Institute of Palliative Medicine is one of the pioneering institutes in the country in the growth of palliative care and the start of palliative care. And she's also the chairperson of Board of Examinations for IAPC. IAPC is Indian Association of Palliative Care. And she's very much involved in the clinical duties, I think, till the Corona time. And in fact,
Dr. Sridevi?
Yeah, can you hear me now? I think I lost something in between. Yeah. Okay. So, in fact, it is good that now she's free to take some of the sessions through online platform. Otherwise, she would have been really busy in her clinical work in IPM. Welcome, ma'am. Welcome to this session. We have so many doctors attending this session from India as well as from Philippines and Indonesia, as far as I understand. Welcome to this echo session, ma'am. Thank you so much for agreeing to participate.
Doctor, can you unmute from your end? Dr. Lulu Mathews? We can't hear you, ma'am.
Now?
Yes, we can hear you now.
Yeah. So, good afternoon. And it's a really sleeping time in India now. Okay, the siesta time. I don't know what the time will be like in Philippines and Indonesia. I hope you will not snore. That's all. Okay. And the topic is on nausea and vomiting. Okay. Can you see my screen?
Yes, ma'am, we can see your screen.
Okay. What happened? It's not moving. I'll just stop share and restart because it's not moving. Okay.
Sure, ma'am.
Maybe you just have to enable editing in your PPT.
Now is it visible?
Yes, ma'am, it is. Can you change your slide?
Yeah, it's moving. Okay. This is the Institute of Palliative Medicine where I am working, just as Sridevi was talking about. And actually, there's no gap between my retiring as HOD Pediatrics and joining IPM. Actually, it's the next day. So there's absolutely no gap. So this is my 11th year in IPM now. I mean, you must have heard that there are common GI problems in palliative care, so many, like oral thrush, stomatitis, dry mouth, nausea, vomiting, constipation, intestinal obstruction. But today, I am going to tackle only nausea and vomiting. That is all. Because that's what Rajalakshmi has told me to do. So actually, emesis or vomiting, it's a biological defense mechanism. And the idea is to remove any toxic or harmful substances from our body. And naturally, when we take in something bad, at once we feel like vomiting and it comes out. Or we feel so nauseated, we don't continue to take the harmful substance. So actually, it is a defense mechanism. And the process can be explained in 3 phases: the nausea, retching, vomiting. Okay, now what is nausea? Nausea is an unpleasant sensation of the imminent need to vomit. You feel like vomiting, but nothing comes out. Okay, but the problem is in the abdomen. You see, like the person will be holding on to the abdomen, something queasy with the abdomen. And what is vomiting? Vomiting is forceful oral expulsion. So everything in the stomach comes out. And that is associated with contraction of the abdominal and chest wall musculature. Only then the pressure is generated for the abdominal contents to come out. So that's the difference between nausea and vomiting. Now, there are two more words. One is retching. Retching, it's spasmodic and periodic contraction of the respiratory muscles, okay, against a closed glottis. That is again for our own protection. And here also there will be contraction of the abdominal musculature. Sometimes you will get the contents out or you may not get the contents out. Both are possible. So it is like, as you see, the end, you feel like, as if the entire thing is coming out. So bad is the feeling one gets when you retch. And regurgitation. Regurgitation, you see small babies like this, food is brought back into the mouth. There is no abdominal musculature contraction. There is no diaphragmatic muscle contraction. Nothing. No force at all. Simply block the thing come. That is regurgitation. What we are bothered in palliative care is about nausea and vomiting. Okay, so nausea, is a very, very unpleasant sensation, usually in the back of the throat or the stomach. It usually, nausea precedes vomiting, but it need not always end in vomiting. And there are other terminologies, some people say, I'm sick to the stomach. Others say, I feel very funny or queasy, as if they're butterflies. And nausea is also mediated by several neural pathways. Okay, now, just as you would have had your classes on acute pain and chronic pain, nausea and vomiting, especially the chemotherapy-induced, different types. Acute vomiting is occurring within few minutes to hours of taking a chemotherapy. You take the chemotherapy at 9 o'clock and at 9:30 or 10 itself, you start vomiting. But everything gets resolved within 24 hours. Classical example, cisplatin, cyclophosphamide, all these chemotherapy drugs. Then again, delayed. Delayed is usually delayed vomiting. That usually occurs 24 hours after chemotherapy. 24 hours after. So if you had your chemotherapy on Monday, maybe you will start vomiting on Tuesday or Wednesday. Okay, will be worst from 48 to 72 hours, and it can last as long as 6 to 7 days. That is known as delayed vomiting. Now, what do we normally do in order to prevent this vomiting? We give antiemetics. Okay, when a patient is going to receive chemotherapy, but despite giving prophylactically antiemetics, some people start vomiting, and that is known as breakthrough vomiting. Breakthrough, that is breaking out of the control of antiemetics which we have given. Now, there is yet another entity, refractory vomiting. That is really unmanageable. Whatever you do with the currently available antiemetics, it just doesn't settle down. Vomiting does not settle down. And that is refractory. And then there is anticipatory. Anticipatory is a conditioned response. That is, see, if a patient knows that Monday he has to go to the oncology department for the chemotherapy, Saturday or Sunday itself, he starts having vomiting, anticipating the chemotherapy administration. So usually there are different types of vomiting. Okay, and why should we be bothered about nausea and vomiting? It really affects the patient daily functioning. His quality of life will become very poor. And if he is having nausea and vomiting, he will not be compliant. He will even stop taking the cancer drugs, whichever he has to take. And then again, he will even refuse the pain medication. Okay, so not only the patient, but the entire family will be distressed. And why? All because of the reason that he is having nausea and vomiting. So what is it? Our duty as a palliative care professional, we should either stop vomiting or at least reduce the frequency of vomiting, so that the compliance is re-established. The patient starts taking all the drugs as per the schedule, and again hopefully he will also start taking the analgesics, and thereby his quality of life can be improved. Now, nausea and vomiting, such a common symptom, occurring in almost around 50 to 70% of the palliative care patients. And management, in order to manage it, we have to do very accurate assessment. But even then, you see, real good control is possible only in around 60% of the patients. And even to get that 60% control, we need to have very good knowledge of the anti-emetic drugs. That means they act on various receptors. So we should be knowing some idea we should have about the different receptors. Now, this is the worst time for me to talk about receptors because, as I told you, it is a siesta time. But still, see, there are cholinergic receptors, muscarinic, dopamine receptors, D2, histamine receptors, H1, substance P, neurokinin, serotonin receptors, 5-HT3, opioid receptors, mu receptors. All these receptors, the stimulation of all these receptors can result in vomiting. That's a problem. See, for our body to do anything, for everything and anything, there is a representation in the brain. So vomiting, there is a vomiting center in the medulla. See, medulla, as you know, is the ancientmost part of the brain. The most ancient part of the brain, you see. So why is it that medulla has a vomiting center? Because vomiting is a biological defense mechanism. Anything bad gets into the body, it has to come out. So the vomiting center is placed in the most primitive part of the brain. This was the part of the brain which is most primitive. So this is the vomiting center. And vomiting center has various receptors, the cholinergic receptors, histamine receptors, and serotonin receptors. 5-HT3 is serotonin. Now, vomiting center just cannot initiate vomiting on its own. It has to receive impulses either from the chemoreceptor trigger zone. This is brain. Chemoreceptor trigger zone is again in the medulla, close to the vomiting center. So if it receives stimulation from the CT cell, chemoreceptor trigger zone is CT cell, vomiting center will be stimulated. If it receives impulses from the cortex, again it will lead to vomiting. If the vomiting center receives impulses from the GI tract, that will lead to vomiting. If the vomiting center receives impulses from the vestibular tract, that will lead to vomiting. So you see, in the vestibular system also, there are cholinergic receptors, histamine receptors. Okay, in the GIT, there are serotonin receptors, dopamine receptors, and NK, neurokinin receptors. Whereas you see the CT set, my lord, so many receptors, dopamine, serotonin, opioid, neurokinin, histamine, such a lot of receptors which when stimulated, they send action potential to vomiting center, resulting in vomiting. So vomiting center, there is it, but it has to be stimulated by impulses from either the CT cell, from the cerebral cortex, from the GI tract, or from the vestibular system. Is so much clear? All are muted?
Yes, madam. Yes.
Yes.
Okay. Yeah. This is a very complicated diagram. I'll be coming back to it. Let us leave it now. Now I thought if I give example, see, suppose you are very much bothered about chemotherapy-induced nausea, vomiting, and radiation-induced nausea vomiting. You know what happens when a patient undergoes chemotherapy and radiation? You see the GIT. From the GIT, the serotonin receptors are stimulated. Okay, when the serotonin is liberated, that goes and stimulates the CT cell, chemoreceptor trigger zone. And from there, impulses go to the vomiting center. So initially it starts in the GIT from where serotonin receptor stimulated, and then you see goes to the CT cell and from there to the vomiting center. So if you know, if you have this knowledge that chemotherapy and radiation-induced nausea vomiting is as a result of the stimulation of serotonin receptors, we can block this by giving anti-serotonin. That is our, anybody take a chance? Cetrons. You see, so that is why cetrons are considered to be good. Ondansetron, palinosetron, all types of cetrons. That is why they are very useful in chemotherapy-induced nausea vomiting and radiation-induced nausea vomiting. Okay, that is the reason why I am telling you should know how certain things act. If you know that chemo and radiation act via serotonin receptors, you can block the serotonin receptors. Now, see what is happening in the gut, you know, stimulation of gut, chemoreceptors in the gut, stimulation of stretch receptors in the gut, stimulation of vagus, sympathetic fibers, and liberation of serotonin, histamine, acetylcholine, substance P, all these, you know, stimulating the receptors there. And histamine release can also lead to nausea. That is why you see when we go for some journeys, you know, to overcome the nausea, we take antihistamines, right? Now, there are substance P receptors also, and these can have receptors not only in the gut, but also in the vomiting center directly. Okay, so this is substance P. This is blocked by apropeptin. The new apripeptin, the latest, and I mean a new into the market anti-emetic. And acetylcholine, you know, these cholinergic receptors, what do? They increase the gut motility as well as secretion. So, you know, imagine sometimes, you know, we take some, not that we take poison, something. When we see some patients coming with poisoning, there will be vomiting as well as loose motion. Okay, because gut motility and secretion. So all these are actually a defense mechanism, biological defense mechanism. Now, if you take post-operative nausea vomiting, see, for the surgery, the doctors will be giving anesthetic agents, opioids, fentanyl, morphine, and this morphine, you know, it will relieve the pain, but it stimulates the dopamine receptors in the CT cell. It stimulates the mu receptors in the CT cell. It even stimulates the opioid receptors in the vestibular system. So as a result of all this, you see the patient has vomiting. So when a postoperative patient vomits, we know it is as a result, especially if he has been given opioids, that is acting through all these mechanisms, mainly the dopamine as well as the mu receptors. So we should be giving an anti-dopamine drug. For example, metoclopramide, or drugs which block the mu receptors like haloperidol or metoclopramide itself. So only if you know the mechanism, you will be able to use the right antiemetic. Now, again, the vestibular apparatus. You see this couple traveling in the car, going in the highway, and what's happened? The vestibular system is stimulated, okay, as a result of histamine and cholinergic receptors. They at once they go to vomiting center, stimulates the vomiting center, and the result is vomiting. So you should be giving in such cases, those drugs which will block the histamine receptors. That is why for motion sickness we use antihistamines. Now again, cerebral cortex. Sometimes you see, when you see certain bad food, I mean, dirty looking scene. You are going along the road and you see fecal matter or a vomitus, something like that, you know, or you see the smell when you're traveling in the bus, somebody in the front of the bus is vomiting and you are getting the smell of vomitus, or it may be a memory. All these things, you know, direct stimulation from the cerebral cortex to the vomiting center. So again, the net result will be vomiting. So vomiting can initiate vomiting, but mostly it is stimulated by impulses coming from CT cell, cerebral cortex, GIT, as well as the vestibular system. Is it clear so much? Is it
Yes.
clear?
Yes, yes.
Okay. Now this is that confusion picture which I showed you. You see this. In the behind, you can see faintly the picture of the brain here. But we are bothered only about this, the vomiting center in the medulla. And this is the CT set, chemoreceptor trigger zone. That will be stimulated by chemotherapy drugs, by anesthetic agents, by opioids, so many things. Why? Because here there are receptors, several receptors, dopamine receptors, serotonin receptors, opioid receptors, neurokinin receptors, and histamine receptors. So you see, once these chemoreceptor trigger zone is stimulated by any of this, because so many receptors are there, naturally impulses go, action potentials go to the vomiting center, and the result is vomiting. Is that clear now? Okay, so in order to block this vomiting, we have to give anti-dopamine, anti-serotonin, anti-opioid, anti-neurokinin, anti-histamine. So this is the thing. So you should be knowing chemotherapy that mainly acts through serotonin. Opioids mainly act through mu receptors. So only if you know that, you know, you will be able to give the right anti-emetic. Now this is, as I told you, you know, bad smell, sight, memory, yeah, all these, you know, stimulate from the cortical center, cerebral cortex. Again, impulses coming to the vomiting center. So here it is a reflex action, you know, it is very, very. So you see, this can be tackled by giving benzodiazepines. Benzodiazepine. Yeah, this is what. For example, if a patient, you know, he remembers, oh, today is Tuesday. Okay, next Thursday I have a chemotherapy. So some patients start vomiting today itself, anticipating. For such patients, you see, you need not give metoclopramide or NSAID. Good control will be obtained by giving benzodiazepine, because here the impulses are coming, reaching the vomiting center from the cerebral cortex. Now, you see the stomach here. Stomach, intestine, GIT. Okay. Again, having receptors like serotonin, dopamine, and neurokinin. So you see anything happening here as a result of chemotherapy, as a result of surgery, as a result of radiotherapy, anything. There is stimulation and it goes up to the CT set and to the vomiting center, resulting in vomiting. So if you know that this patient is on some chemotherapy, you know it is mainly as a result of 5-HT3. Whereas if the patient is vomiting after a surgery, after mainly surgery, again there, you know, there you can give cholinergic receptors. Or sometimes it may be, you see, after a surgery, the whole entire GIT will be in a sort of stasis state. Okay, very, I mean, not at all, no movements, no peristalsis. Then we can give a prokinetic drug. So that is why, depending upon the causative agent, we should be changing the antiemetic. And these are certain cholinergic, mainly muscarin 1, hyoscine, drugs acting, Antihistamine, mainly we use promethazine, diphenhydramine. Dopamine, metoclopramide, domperidone. And serotonin, all the cetrons, different types of cetron. The first to come was ondansetron. There are several cetrons now. Neuroleptics, that is antipsychotic drugs like chlorpromazine and haloperidol. Haloperidol we use a lot. I'll come back to it. And substance P, that is neurokinin, aprepitant, and rolapitant. All of this act at the level of substance P, neurokinin receptors. Now, this is the first picture which I told you. It's very confusing. And what I was showing was I split it up into small sections. Okay, so this is the CT set being activated by chemotherapy, anesthetic agents, opioids. So you can give those drugs which will block the receptors in the CT set. And if the impulses are coming from the GIT, you can give those drugs which act on the receptors present in the GIT. And if the impulses are coming from the higher cortical centers, we can block it by giving a drug like benzodiazepine. And if it is from the labyrinth, again you can use either cholinergic or antihistamine, because these are the 4 ways in which vomiting center can be stimulated. Apart from directly, the vomiting center itself can induce vomiting, but more important than that is the impulses coming from all the 4 areas. So if you have an idea what is causing the vomiting, choose the best antidote, anti-emetic. That will settle the problem for you. Now again, you see chemoreceptor trigger zone. Mainly, usually, all drugs like opioids, chemotherapy, they all act at the level of chemoreceptor trigger zone. And any biochemical aberration like hypercalcemia, uremia, liver failure, okay, all act at the level of CT cell. Sepsis, when a patient is in fulminant sepsis, that person can have vomiting. Again, the action is at the level of the CT cell. When a patient gets radiotherapy, again, due to serotonin receptors, he can have vomiting acting at the level of CT cell. Now, if you come to vestibular system, some tumors there, opioids can act at the level of vestibular system, and also motion sickness. Motion sickness, I showed you the picture. Then cortical, I told you about the anxiety induced. Okay, even raised intracranial pressure can also lead on to vomiting. Periphery means in the GIT. So again, radiotherapy, chemotherapy, GI irritation. This irritation may be induced by drugs. If you take NSAIDs, that can lead on to. So it is GI irritation or inflammation or obstruction or paresis, that is postoperative paresis, compression by tumors. All this act at the level of GIT. So any impulse coming from any of these areas can send impulses to vomiting center, and the patient can lead to vomiting. So what are the drugs you see? The drugs should be as per the patient's condition and to some extent the preference also. Okay, because sometimes you see there are 1 or 2 drugs from which we can choose. Oral route is usually the best, unless he or she has severe persistent vomiting. Usually we can control with oral route. Then in Western countries, there are suppositories, drugs which can be given sublingually, and also transdermal patches. We don't have it here. So when you manage vomiting, treatment should be mechanism based and not generalized. Usually what we do, we write the latest drug which has come into the market, and the patient's vomiting will not be controlled. The latest drug need not be the one acting on the receptor which you want to treat. So always you have to consider the mechanism. Now, if you take drugs which cause nausea and vomiting, some drugs, for example, opioids, they can directly act on the CT cell and cause vomiting. Whereas certain drugs like NSAIDs can cause gastric irritation. Okay, classical example is NSAIDs. Or some drugs like morphine, it can cause again gastric stasis. That means the peristalsis will be cut off. Or sometimes, certain drugs can directly act on the vagus, and vagal stimulation can lead on to vomiting. So you see, the treatment should also be according to the mechanism. Suppose the patient is vomiting after taking opioid, then you have to give a drug which acts at the same receptor, like haloperidol acting on the CT cell, or metoclopramide, which can act both on the CT cell as well as in the GIT periphery. But if the vomiting is as a result of a gastric irritant like NSAID, then you have to give a PPI, proton pump inhibitor. So that is why I am telling, depending upon the mechanism. And we cannot say for all drugs same antiemetic. You have to consider how is this drug causing vomiting, and then depending upon the mechanism you choose the antiemetic. Now, almost all biochemical causes, uremia, hepatic failure, ketoacidosis, hypercalcemia, toxins, infection, they all stimulate the CT cell, directly stimulating the CT cell. Okay, raised ICP. It can be either primary brain tumor or secondary mets. Both ways, it can lead on to stimulation of raised ICP, can cause stimulation of the vomiting center. So here the treatment would be one, steroids, because you see raised ICP. So anti-inflammatory drug like dexamethasone has a very good role. And definitely you can plan any palliative radiotherapy. And antihistamines are also helpful here. Okay, other causes of nausea, vomiting, movement associated. I told you motion sickness. Here we have to go for use antihistamines. Anxiety induced, I told you, impulses come from the cerebral cortex. So go for benzodiazepines. Similarly for anticipatory also, we give benzodiazepines. Okay. So the principles of treat the cause if possible. Environmental measures should be looked into. When you consider the antiemetic use, anticipate. When you start a patient on morphine, you know the patient will have vomiting. So anticipate and start on antiemetic. Use adequate dose, use regular dose. And always think at which receptor is this drug acting. So sometimes you may have to combine antiemetics, because you see a uremic patient may be having a gastric stasis. Okay, so for uremia, it is a metabolic state. So ideal one is haloperidol. But gastric stasis, there you might like to give a prokinetic drug like metoclopramide. Anticipate the need for alternate route. Best is oral. Sometimes you may have to, if he is having persistent vomiting, you may have to give sub-Q or IV. Again, you see the stimulus, drugs, metabolism, mainly acting at the level of chemoreceptor trigger zone. Motion sickness, position, vertigo, vestibular level. And visceral, mainly the organs. So these are the receptors, and all of them will cause stimulation of the vomiting center. So when you want to learn about nausea, vomiting, you should have one of these diagrams in your mind, and then it will be easy for you to choose the best one. So you see, dopamine antagonist, D2, antihistamines, anticholinergics, serotonin, other drugs are also available. If you take haloperidol, it's very good for morphine-induced vomiting. It directly acts on the CT cell. Okay, very single dose will do. And when you start the patient on morphine, you can give haloperidol for about 2 days. HS dose will do. And after 2 days, vomiting will settle. Metoclopramide is a wonderful antiemetic. Various actions. It is a DT antagonist. It has a serotonin antagonism. It is cholinomimetic. In that, it is because of the cholinomimetic action that it has the prokinetic. It will induce peristalsis and push the gut forward. And the dose is really very wide, 30 to 120 mg per day. We start with always 10 mg 3 times a day. So nausea, vomiting, after clinical evaluation, you should document why is he vomiting. Is he vomiting due to gastric stasis? Is he having intestinal obstruction? Is he having uremia, hepatic failure, infection, toxins? Is it due to drugs? Is it due to raised intracranial pressure? You note it down. Okay, and then ask the patient to record the symptoms, preferably using a diary. How many times you vomited yesterday? Time. How many times you vomited today? Time. And correct all the correctable causes. Sometimes it may be drug induced. It could be severe pain. Severe pain itself can cause vomiting. So manage pain. It could be infection. With antibiotics you treat infection. It may be a cough which is leading on to vomiting. Give cough suppressants. It could be hypercalcemia. Treat the hypercalcemia. It could be anxiety. Treat anxiety. Okay, and prescribe the most appropriate antiemetic, because you should consider drug is causing which receptor, which drug to act on that particular, and always give regular dose, 3 times, 2 times, 4 times, not SOS or PRN dose. Okay, if ever possible, give oral. If it's not accepting orally, only choose a parenteral route. Okay, and when I told you metoclopramide is very good, you can use it for gastric stasis, functional bowel obstruction. Metoclopramide is a very good drug, but only thing you have to be bothered about the side effects. If you give too much, it can lead on to extrapyramidal features. Okay, so antiemetic acting principally on the CT cell. That is the one which we give for all chemical causes of vomiting. Chemical causes means uremia, hepatic failure, toxin, ketoacidosis, infection. All of this act on the CT cell. So choose a drug like haloperidol acting on the CT cell. Now, single antiemetic may not be always adequate. You may have to go for a combination. Suppose it is raised ICP and uremia. For raised ICP, you have to give dexamethasone. For uremia, you have to give haloperidol. Okay. Persistent vomiting, you can either choose subcutaneous or intravenous. Always keep in mind side effect of this metoclopramide, extrapyramidal side effect. And if the nausea and vomiting is drug-induced like morphine, haloperidol is very good. If it is radiotherapy, one of the cetrons, ondansetron, granisetron, anything. Chemotherapy also, ondansetron, granisetron, but only thing, with chemotherapy, you would always give, along with the cetron, steroid also. Okay. Uremia, haloperidol. Okay, raised intracranial pressure, dexamethasone. Bowel obstruction, I will come tomorrow then. Delayed gastric emptying means sluggish. So there you have to give a prokinetic like metoclopramide. Gastric irritation, a proton pump inhibitor. Okay, so different mechanisms may be at play. Okay, different mechanisms in the case of morphine. It can act at the level of CT cell. It can act at the level of vestibular. It can act at the level of GIT. So you see that is it. Whenever you give morphine to a patient, you should be giving an antiemetic also. Drug of choice would be either haloperidol or metoclopramide. You can give only for 2 days. After 2 days, vomiting will settle. And dexamethasone can It can reduce the permeability of CT cell, and that is how it decreases the vomiting. It also reduces the GABA content. Thereby also it reduces vomiting. It reduces inflammation, and it also reduces the pressure. So 3 or 4 mechanisms by which dexamethasone relieves vomiting. If a patient is having irritation of meninges, okay, we can give a combination of dexa and mannitol. But along with that, if you refer Western books, they also give levomipramicin. But that is not available in India now. And again, levomipramicin is as per the Scottish guidelines for palliative care. We don't have it here. We don't give it also. Anxiety induced, what we give is lorazepam, but again, Western literature, they advocate levomipramicin. Abdominal tumors, you see, anticholinergics are very good because GIT, a lot of cholinergic muscarinic receptors. We can also give steroids to reduce the tumor mass, and haloperidol because dopamine receptors. Whereas if it is for gastric stasis, you want a prokinetic like metoclopramide or domperidone. And again, for reducing the edema, we can give dexamethasone. Review the antiemetic dose every 24 hours. And take note how many times the patient has used SOS dosage. If inadequate response, you have to review your diagnosis. Even after reviewing the diagnosis again, if vomiting controls, you have to go for an alternative antiemetic. That means, you are not tackling the real receptor. Sometimes you may have to add a second antiemetic also. So establish a likely cause, identify the most likely pathway, see which are the receptors involved, choose the most potent antagonist, choose the most appropriate route of administration, review after 24 hours. If needed, you can add another antiemetic. And always go for regular dosing and not for PRN dosing. Titrate the drug dose accordingly. Okay? That is it. And non-drug measures, fresh air, bed rest to avoid the vestibular stimulation, good oropharyngeal hygiene, avoid smells, frequent small meals, food selection, whatever food the patient likes, relaxation and distraction. It could be anything, self-hypnosis, muscle relaxation, any way to divert the attention of the patient. Nutrition advice is very important, small frequent meals. And try consuming, most of the patients, they would like to have a good breakfast. So give a good breakfast. Maybe they will eat less at lunch or dinner. Give food or drink that's easy on the stomach, not those drugs which take a long time to digest. Do not force yourself to eat. No, never, don't force. Cold food or even room temperature, usually patients prefer that to very hot food. Avoid fatty, sweet, spicy food and avoid carbonated drinks. Okay? Make someone else to prepare food. If you prepare the food, if the patient herself prepares the food, it will not be proper. Someone else should be preparing the food. And if a person is having difficulty in eating, especially suppose he is on hard diet, you have to go for some relaxation. Okay, if it wants some sugar, give it. Okay, keep the mouth clean, do oral care, wear loose fitting clothes, fresh air, limit bad sounds, sights and smell, and call your doctor or nurse if you cannot. And some newer antiemetics are palinosetron. This is the new one. Half-life is long, 40 hours. Very effective. And I told you about aprepitant. It is a neurokinin 1 receptor. So tackles both peripheral and central action. And also it can be useful not only in acute vomiting, but also in delayed vomiting. So in a nutshell, document the most likely cause, treat the potentially reversible cause, review the dose after 24 hours. If nausea, vomiting persists, review the cause. Remember, 1/3 of the patients will need more than one antiemetic. And if you have started the patient on parenteral, please revert back to oral after 72 hours. If he is not having any vomiting, go back to oral. Thank you very much.
Thank you so much, madam. Thank you so much for the elaborate presentation. We have heard about various types of vomiting. We have heard about various receptors, how it conveys impulses to the vomiting center, how the vomiting center coordinates things. And we heard in detail about chemotherapy-induced nausea and vomiting, post-operative nausea and vomiting, various receptors in each center, and which are the drugs that can be used to block these receptors, right? So I think the most important message Madam conveyed is that to use the appropriate antiemetics, understand why this happens and understand the mechanism and using an appropriate antiemetic. We can take up a few questions before we move on to case presentation.
Yeah, somebody asked if PRN is same as SOS. Both are same. PRN dose is same as SOS dose.
Ma'am, I have a question. My question is, how do we, you wrote in the end that sometimes we may require more than one antiemetic. So how do we make that assessment?
See, before adding the second antiemetic, you have to be sure that you are choosing the right antiemetic. So again, review the diagnosis. Why is this patient vomiting? Is it drug-induced? Or is it due to motion? Or is it due to anxiety? Or is it due to gastric stasis? You have to go over in your mind. And even if it is drug, is this drug causing stimulation of opioid receptors, or is it drug causing irritation? So like that you have to consider. And again, after everything, you come to the conclusion. Again, it is the same. At that point, again, maybe he's having a raised intracranial tension, or he may be a uremic patient. So if you think there is another cause, then you are justified in adding, provided the first antiemetic has been given has been properly chosen and given in the right dosage, in the right frequency, along the right route.
Thank you, ma'am. Sometimes 2-3 receptors can be activated at one time. That time we can give at a time.
I didn't catch your question, sorry.
For example, the receptors of in the gut are also activated, as well as receptors somewhere else are also, for example, in vestibular or wherever. So if they are both activated at the same time.
See, for example, if you take morphine, it stimulates the mu receptors in GIT, mu receptors in the CTZ, mu receptors in the vestibular apparatus. So you can give haloperidol. Wherever mu receptors are there, haloperidol will act. That's all.
Thank you.
And somebody...
There's a connected questions in the chat about morphine.
If you start morphine for the first time, should definitely, whenever you start a patient on an opioid, you should be giving an antiemetic, and the choices are between morphine and between metoclopramide and haloperidol. Haloperidol can be given small dose, single dose bedtime, 2 days. Whereas metoclopramide, it has to be given 3 times a day for 2 days. Either of the two.
For radiotherapy also we should preventively give a antiemetic, or we can wait if the patient
definitely if you anticipate and give, that would be very good.
Okay, even for radiotherapy.
Yeah, radiotherapy, especially if it is for the organs, not head and neck, in the abdomen or pelvic region, there will be definitely stimulation. That is, the cetrons are very good. 5-HT3 cetrons.
Okay, thank you.
There is one more question regarding morphine. What should be the route, whether it is oral or...
See, don't wait for the patient to vomit. You should be giving the antiemetic along with morphine. Then the patient will not vomit. and that is given orally. Only when you do a morphine trial, we give morphine intravenously. That is the only time we give metoclopramide also intravenously. Otherwise, oral only. Oral morphine, oral metoclopramide. Any other questions?
Any other questions?
For tramadol also, we should give an antiemetic.
Yeah, tramadol is not as, it does not cause as much vomiting as morphine. But even then, if you are using it in an elderly person, it would be good to give an antiemetic.
Which should we prefer to give? Which antiemetic should we?
Yeah, same. It is an opioid. It's an opioid. All opioids act on the mu receptors.
So you should prefer haloperidol or metoclopramide?
Metoclopramide or haloperidol.
There is another question regarding hydromorphone or fentanyl patch. Do we need to give antiemetic?
For example, fentanyl, the side effects are not as much as bad as in the case of morphine. But when you start the patient on fentanyl, it is good that you give an antiemetic. But definitely, the laxative needed will be much less when you use fentanyl. But as for emesis, it can also lead on to vomiting. So better that you give antiemetic for 2 days.
So there is another comment. Obese patients are more prone to get post-operative nausea and vomiting.
Obese patients
Was
are
that a
prone for
question,
all.
Dr. Savitri?
No, obese patients are prone for all sorts of complications, not only this. Any other?
If you cannot talk, then you can just type it in the chat. Madam will get answers. Any other questions from the participants? For anticipatory nausea and vomiting, how early should we start the medication?
When the patient complains of vomiting, you start. That is the best thing.
Is it okay to give a week long?
No, they don't usually have it week long. They don't. They are very clear, very, very clear about that. They will say, day after tomorrow, I have to go to hospital for chemotherapy. Even today, I feel like vomiting. I feel like vomiting. That's what they say. Not even I vomited. So you can give benzodiazepine.
So do we need to give that from the day they are telling they're anticipating vomiting or at the day of chemotherapy? I think that's
No, when usually it is not on the day of chemotherapy. Day of chemotherapy, what they have is acute vomiting, drug induced. That is it within even minutes of taking the chemotherapy. Anticipatory is ahead of that. Suppose it is due Thursday, even Tuesday or Monday itself, they start having vomiting. Reflex mediated.
Any last few questions before we move on to presentation? Raju, should we start the presentation then? I don't think there are more questions coming.
Yes, I think we can start with the case presentation. If you have any doubts, you can put it in the chat. Ma'am will be clearing it. The case presentation will be taken by Dr. Edward. Dr. Edward, can you unmute and start your presentation?
Okay, is it audible?
Yes, it is. Can you speak a little more louder?
Okay. Thank you for this opportunity. First of all, thank you to uh, Dr. Lulu to give me a broad explanation about the knowledge in nausea and vomiting. I'll try to take my case presentation. I'm a internist from Cipto Mangunkusumo Referral Hospital in Indonesia in Jakarta. Okay, next. My patient is 55 years old. She is diagnosed with cervical cancer stage 3B progressive disease with cancer pain, vomit, and constipation, hydronephrosis bilateral, and malnourished. Okay, next. Abdominal pain about 7 days before he in charge in hospital, and she had an eating problem. After it, patient felt nausea and vomit since external radiation about 30 times. Jadi, so she already fulfill the external radiation about 35 times. And she complained about bowel movement just once in every 7 days since February 2020. And about a few days, she's she's complained about diminished urinary since 14 days earlier. Next, please. History of illness. She got bleeding from the vagina, and he go to the doctor. So he diagnosed with cervical cancer and done the internal radiation about 3 times last in April 2020. Next. This is the physical examination. Is well enough with compos mentis. The face looks sad. The body weight is underweight. The vital signs in normal range, but the heart rate is about 100 times per minute. So almost tachycardia. And the fast scale is about 8 to 9. The conjunctivity is pale and she feels pain in suprapubic. Next. This is the investigation. After check, the hemoglobin is just 5.6 and about EGFR is diminished to 24.7, so it's very acute in his kidney injury. From the ultrasound urinary tract, it's a hydronephrosis bilateral, right grade 4 and left grade 3. And from the pathological cervical, the pathological is squamous cell carcinoma, not keratinized, and poor differentiated. This is the psychological aspect. The marital status is widow. She's an employee, but her income from her relatives for monthly. The husband died because of heart attack about 4 years ago, and her first child passed away about 2 months after he delivery about 2 months years old. Now she lives with her 2 children. she distressed with her ill and suffer with her ill. Looks very depressed. For the medication in the hospital, we give supportive psychotherapy, spiritual guidance, and we try to family meeting regularly. And for the low hemoglobin, we give transfusion, packed red cell. For the nutrition, we start gradually from about 900 kilocalorie and increase to avoid revealing syndrome. And then we give parenteral fruit and ACL 0.9 500 milli per 8 hours. And we done cumulative fluid balance. For the pain, we drip morphine about 5 milligram per day and give breakthrough 1 milligram bolus if necessary. And for the vomit, we give ondansetron 3 times 8 milligram intravena. And for the constipation, we give laxative 2 times 15 milliliter orally. The main concern is how to relieve the suffer in this patient, the relief pain, relief nausea and vomitus, and relief constipation. The summary: female 55 years old with cervical cancer stage 3B, progressive disease with cancer pain, vomit, constipation, hydronephrosis bilateral, and malnourished. The discussion points for today is are the best treatment for this patient, what we can do, and how can we help her to relieve the suffer. Thank you.
Are you not discussing?
Yes, no. They'll be asking their concerns, and first we will ask the participants whether they have anything to suggest from what they have heard from you, and then we'll ask the expert how to go about this patient. That's how we usually follow. So over to the participants. Madam has discussed in very detail about how to like what can be the mechanisms of vomiting in almost all possible scenarios she has mentioned. So I would like to hear from you all. Like, what would you think about managing this patient? How do you want to go about it? What kind of treatment that you want to offer to this patient to suggest from your side? First question about nausea and vomiting, and then we'll go about how can we help her to relieve the suffering. Either you can unmute and tell, or you can type.
Why total silence like this?
It's very common after the discussion, ma'am. Then
Eh?
that is very common after the discussion. Usually there will be a silence. So there is a chat. Nausea may be due to reduced GI motility and due to irradiation and also due to morphine. Any others? It will be good if you can unmute yourself and talk before we ask madam's inputs.
Excuse me, ma'am. Maybe I want to give more information.
Sure.
After she treat with ondansetron, the nausea and vomit still continues. So we'll try to give metoclopramide, but it's still ongoing. Maybe Dr. Lulu can give solution. Thank you.
Madam, there are more suggestions coming up in the chat. It can be due to dietary insufficiency, or again, metoclopramide or haloperidol should be given. Madam, now what would you think, Dr. Edwards? He has added metoclopramide also. So what else would you like to contribute?
See, first of all, Edward, you should have written, these are the symptoms. What are the symptoms which this patient is having? You have mixed up signs and symptoms. What are the symptoms she is having? No, you need not show the slide. You can just answer.
Oh, okay. She feel the symptoms is feel pain, very pain with her in lower abdomen, ma'am, and then feel very sad. Just and the other things is he kept by herself.
No, pain, I got it. Then, any other symptom she has? Only pain?
Yeah, only pain for the last time I follow up.
Not only pain. See, when you work up a patient, you should go through the patient's concerns. It's not only pain. She has pain, she has vomiting, she has constipation. Why don't you? And her urine output is reduced. So first of all, when you see a patient, you should list all the symptoms. List all the symptoms, and then talking again with the patient, you should find out which is the most distressing symptom. So what is the most distressing symptom here?
The most distressing symptom is just feel vomit.
What is the most distressing symptom?
Feel nausea, ma'am.
No, I think it should be pain.
Oh,
Pain
okay.
you said 8 to 9.
Yes, I know.
So what is she getting for the pain? Where is the pain?
I give her morphine.
Where is the pain? See, do you know about the PQRST of history taking in pain? Have you heard about that? Sridevi?
Yes, ma'am.
How many days they are having this class?
They had sessions on pain. Right? They had sessions on pain, yes.
So, Edward, you tell me, have you heard about the PQRST in history taking of pain?
Yes.
Yes. What is P stand for? Huh? See, you should know how to take a pain history. That is very much needed. P stands for palliating factors and precipitating factors. When does the pain become more? What relieves our pain? What is the quality of our pain? Is there radiating pain? Yes, you have answered. Severity. Temporal. When is she getting? During daytime, during nighttime, when she voids urine, when she moves bowel. Nothing. You have not taken any details regarding the pain. You just told me pain is in the supra area. So why should she be having pain in the suprapubic area?
Oh.
Why?
Not
only anybody can answer.
Hello.
What could be the cause?
Hello, ma'am. It's provocation because hello.
Hello, you tell.
We can hear you.
Hello.
We can hear you, Doctor.
Oh, okay. The pain provocative because he movement, and sometimes if he try to bowel, and the quality is raised if he move. If she try to move from bed to other position. The region
Okay.
she
You
feels
said
just
when she moves her bowel, she has pain.
yeah.
And what is her bowel pattern like?
The bowel pattern for the last time she just once for a week. So
Once
when
a week.
she
So is that normal? Is that normal?
no, it's not normal.
No. Yeah. So she is severely constipated. How many days
Oh,
since she has moved her bowel? You have seen the patient today. How many days back did she move her bowel?
pardon. Hello.
You didn't ask. Okay. Suppose it is 7 days, that fecal impaction, that itself can lead on to retention of urine in the bladder, which can lead on to urinary tract infection, which can lead on to suprapubic pain. See, that is the way you should be considering.
Okay, ma'am.
You have mentioned pain only in the suprapubic region, so I believe you, and if that is so. And another cause for a suprapubic pain is she is a case of CA cervix. Okay, CA cervix means again the pain will be down there. And you are giving morphine. How much of morphine is she getting?
Due to there is increase.
How much of morphine is
I
she
give
getting?
5 milligram drip in for 24 hour, ma'am.
Okay, 5 milligram intravenously. If you want to convert it into oral, how many? What what is the multiplying factor to convert it into oral dose? 5
Equally,
milligram intravenously will be the same as
5 milligram orally.
eh?
5
multi
milligram oral.
no, the exact oral will be multiplied by 3. So
3.
the patient is getting just 15 milligram in 24 hours.
Pardon, ma'am.
In 20
Not audible in me. Pardon.
the
Hello,
patient
hello.
is just getting 15 mg morphine in 24 hours.
Okay, 15 milligram oral in
That is
24
all.
hours, ma'am.
That 5 mg intravenously will be equivalent to 15 mg orally.
Orally.
But even now, her pain was is 8 to 9.
Yes.
Yeah. So how will you address her pain?
I'll try to assess about the pain because from psychological maybe.
See, she's having suprapubic pain, you said.
Yes.
Okay. And you are giving morphine, but the pain is not relieved with morphine, with 5
Yes.
mg 24 hours. So what can you do next?
Can increase the dose of morphine.
Before increasing the dose of morphine, what should you be checking? She is
Oh,
CA cervix.
evaluate again about the etiology, the identified again the what is provoked the pain, such as
See,
fecal
Edward,
infection
what is the manner in which morphine gets eliminated from the body? By which route?
from the kidney.
Kidney. So before you increase the dose, especially because she is CS cervix stage 3 progressive disease bilateral hydronephrosis. So what will you do before pushing up, increasing the dose of morphine? What else will you do?
Maybe try
Investigation.
to uh, do nephrostomy.
No, my lord. Why nephrostomy? See, what basic investigation should you do?
Renal function test, ma'am.
It is renal function test. What is the
Oh,
serum creatinine of this lady?
serum creatinine increase.
How much?
Uh, The creatinine about 2.2, ma'am.
2.2, not very high, but still it is high. So, so what would you do?
Maybe give hydration for decrease the creatinine.
How can you decrease creatinine? Because she is already in hydronephrosis. Why is it that you are giving her intravenous morphine? Why not orally?
Because the bioavailability is 100%. The bioavailability in intravenous is 100%, miss.
No, she can swallow food, isn't it? Can she take oral medication?
Yes, she
Yes.
can.
Why don't you give her orally?
Is it because of the vomiting, Dr. Edward, that you tried to give IV?
For no, because to try to relieve the pain as soon as possible.
To relieve the pain, you cannot relieve the pain with 5 milligram morphine in 24 hours. You can never.
Okay.
You can never. Okay, the best thing would have been to start on oral. Okay, what antiemetic have you given?
I give ondansetron.
Why did you give ondansetron? Why do you give that?
Because it can block.
What is the cause of vomiting in this patient? What could be the cause?
Could be from pain, her pain.
One is pain, okay, I agree. And you are not managed her pain properly. Second, more probable cause.
Ma'am, I think that particular question should be answered by everyone. What can be, because you just took a session on that. Everyone can suggest why, what is the reason?
Yeah, probably because of the uremia.
One is caused good uremia. Any other cause?
Morphine.
It could be due to morphine, but
Someone said radiotherapy.
Radiotherapy was long back. He said 24 days back. Something like that he said.
Someone said constipate. Two people are telling constipation.
Yeah, constipation. So several reasons for her to vomit. So what can you do? You are seeing the patient today. Now, what can you do? You have mentioned constipation. You have mentioned pain. You have mentioned uremia.
Should give a laxative for the constipation.
Treat the treatable. Okay, what is the treatable?
Should give laxative for the...
See, if it has been 7 days, if she has passed her motion 7 days back, laxative will not help. You will have to do a per-rectal examination. And if there is fecal matter, you have to manually remove it. And then maybe give even a per-rectal enema. And then start her on laxative. That is the schedule for if vomiting is as a result of constipation. So PRE, evacuation, laxative. Now, what is another cause for vomiting you said?
Uremia.
So what is the ideal antiemetic if it is uremia?
Haloperidol.
Haloperidol. Why? Why haloperidol?
Because it can block all receptors.
No, because all infections, toxins, metabolic conditions, they all act on the CT set. Act on the CT set. Okay, because uremia is a metabolic problem acting on the CT set through dopamine D2. So haloperidol would be good. Any other cause for vomiting?
Morphine, someone has mentioned.
Yeah, morphine, she is on vomiting, but you see, you are already starting her on haloperidol, considering uremia. So that haloperidol will also look after the vomiting due to morphine.
Morphine, oh, yeah.
Got it? Okay.
Got it.
What else could be the cause of vomiting?
Anxiety, ma'am.
Anxiety. Why should she? You have not mentioned that she is anxious at all. She has such a lot of physical problems, and that can definitely make her very anxious. That does not mean that you have to give her anti-anxiety drugs. On the other hand, what you should do, you treat her physical symptoms like pain. Pain is really very, very badly treated here, because just 5 mg in 24 hours. And then again, because she is a carcinoma cervix patient, when you take a proper history, you should find out more about the quality of pain, whether it is burning in nature, whether it is pricking in nature, whether it is radiation. Sometimes you see, it could even be a neuropathic pain. Okay, then you said, yeah. So proper pain management is required, proper management of constipation, and the antidote for morphine, that is haloperidol. And again, if she is having high level of blooduria, haloperidol, same as that which you give for vomiting. So such a lot of changes to be made here. Then you are telling abdominal pain. She is also having abdominal pain. What is the cause of her abdominal pain?
Because movement.
Because of constipation?
Constipation.
Constipation. Constipation could be the reason for the abdominal pain and abdominal discomfort. So that will be relieved when you do a PRE and give a PR enema. The abdominal pain will be relieved. And again, you told me that she has suprapubic pain. Is she having fever?
Sometimes, ma'am.
Eh?
Sometimes she having fever.
Sometimes having fever. That's what I'm telling you. When a patient is not moving bowel regularly, there is bound to be urinary retention, and that urinary retention can also lead on to UTI. So
Infection.
definitely you should be sending the urine for culture and sensitivity, and don't wait for the report to come. If the patient is quite sick, as you said, you can, after taking the urine sample for culture and sensitivity, you can start the patient on empirical antibiotics. Do you get it?
Yes, I get it. Thank you, ma'am. Actually, in Indonesia, it's unfamiliar using morphine in the condition decrease in renal condition and using haloperidol for antiemetic, ma'am. This is for first time I got from your lecture. Thank you very much.
Yeah. All kidney patients, not that morphine cannot be given. We can give morphine, but only thing, normally we give morphine every 4 hours. But in those patients with a kidney problem, we can either give it 6 hourly or 8 hourly, depending upon her renal status and depending upon her glomerular filtration rate or creatinine clearance, whichever you are doing. And we don't have facilities for doing GFR. We don't have facilities for doing creatinine clearance. We just go with serum creatinine. The serum creatinine is very high. We don't give it 4 hourly. We give it 6 hourly or 8 hourly. Understood?
Yes, thank you, ma'am.
Any other questions? There was one question before we started the case discussion about how to do assessment in nausea. Nausea is a bit tricky to assess, and understand. So
See,
someone was
nausea
asking
is a
how
very,
to go about it.
nausea, like pain, is a very subjective phenomenon. It is the patient who considers how severe it is, not you. Vomiting you can see, but nausea you cannot see. You cannot see. And moreover, if you take nausea and vomiting, which is more severe? Who asked that question, Sridevi, about nausea?
I'll just go back. It was initially
Yeah.
before we started. Yeah, it is by Dr. Geetika.
Yeah, Geetika.
Assessment is
Which is more frustrating? Is it nausea or vomiting?
Dr.
Which is
Geet,
more Geetika?
nausea. Nausea. Everyone is typing nausea is more severe.
Definitely it is nausea. Nausea is much more. Once you vomit, something, we get some relief. But nausea, you just feel like vomiting, but we don't vomit. So nausea, there's no need for, what's that? What did you grade it? It is what the patient says it is. The patient says he has nausea. Go ahead. And for nausea, haloperidol, which will be much better than metoclopramide. Whereas for vomiting, metoclopramide will be better than nausea, because metoclopramide is a prokinetic also. It will push the peristalsis. Okay, it's a prokinetic also. So metoclopramide will be better for vomiting, whereas nausea, haloperidol will be better.
Ma'am, can I ask about using haloperidol in geriatric, because if I use in Indonesia, my senior will reject that. Thank you, ma'am.
Huh?
How about using haloperidol in geriatric patient?
Yeah, that is because, don't use it in 5 milligram or 10 milligram. I am suggesting as low a dose as 1.5 mg. If you say 1.5 mg, anybody will listen to you. We don't use 5 mg or 10 mg, just 1.5.
Okay. But maybe I want to sharing. Last time I just used 1 milligram. It reject with my senior. Maybe
How many times did you use? How many times a day?
Just one times.
No, his senior refused to give the medicine, maybe because it is an antipsychotic drug.
Yeah,
yes.
That is the problem, especially if the patient's daughter or son is a doctor or a nurse, they know haloperidol only as an antipsychotic drug. So it's really difficult to convince them. In that situation, you should be using metoclopramide. Metoclopramide has dual action, periphery and also at the center.
And Dr. Edwards, you can always show evidence for using haloperidol in nausea and vomiting. Maybe that's a better way to convince seniors when you with showing them the evidence. One last question before we wind up. We have 1 more minute to stop. How to treat nausea and vomiting in total gastrectomy patient?
On FJ, on feeding jejunostomy, are they? What do you mean gastrectomy? Are they on FJ, feeding jejunostomy? Is the patient on feeding
that was removed? No.
Then?
That was removed. After a month, excuse me, ma'am, am I audible? Yeah. After a month, she developed some sort of nausea and vomiting. That is because of vertigo, some sort of dizziness.
Yeah, vertigo, I told you, it is the vestibular system. So you should be using antihistamines will do wonder job. Any antihistamine will do if it is motion inducing. Yeah.
Okay.
Another question. Can I ask another question? This is Dr. Uma.
Yes, ma'am, please.
Yeah. Ma'am, can you highlight, do you have any, in your practice, any role of steroids as an antiemetic? Because as
I
an
told you,
anesthetic,
what were you doing sleeping?
no,
I
ma'am.
also told you the 4
Like,
ways in which steroids act also.
okay.
Definitely
No,
steroids
in
have a
palliative
role.
care, do you use them regularly?
We use it in raised intracranial pressure.
Okay. Thank you, ma'am.
When you get the PDF of the slide, you can see there is one slide mentioning different mechanisms by which steroid helps in controlling nausea and vomiting.
Okay. Yeah, I just wanted to know whether ma'am was like, they use it regularly in palliative care or not, because as
Yes.
anesthetist for PONV.
Only in palliative care. Now I am working only in palliative care.
Okay.
And we do use it regularly whenever the raised intracranial pressure.
Okay, ma'am. Thank you.
Thank you so much, everyone. It's almost 4:31. Thank you so much, everyone, and especially, madam, for your presentation and your time and a wonderful discussion that we had today. And thank you, Edward, Dr. Edward, for coming up with the patient scenario so that we could discuss more in detail, even about pain and as well as in nausea and vomiting. Thank you all other participants for a good interaction through the chat and your answers and responses. And we'll see you on Thursday, right, Raju?
Yes, ma'am. For the continuation of gastrointestinal symptoms only.
Yeah. Thank you so much, everyone. Thank you so much, ma'am. Thank you so much once again.